Aortopulmonary window. Aortopulmonary window is a rare malformation caused by the failure of the fusion or malalignment of the truncal cushions of the truncus arteriosus, which causes communication between the ascending aorta and the main pulmonary artery. Defects can be small as a few millimeters and large as several centimeters. It is distinguished from truncus arteriosus by presence of two semilunar valves. It represents 0.2% of patients with congenital heart disease. There are three categories of aortopulmonary window. Type 1 proximal defect in the medial wall of the aorta just above the sinus of Valsalva. Type 2 is a distal defect on the posterior wall of the ascending aorta near the origin of the right PA, and the complete absence of the aortopulmonary septum is type 3. The physiology of aortopulmonary window is a non-restrictive left to right shunt similar to that of PDA or VSD. In this condition, the systemic arterial circulation mixes with the systemic venous blood, and the magnitude of the shunt increases the pulmonary vascular resistance during the neonatal period. And with the expansion of the lungs and the delivery and the pulmonary vasodilatation occurs, leading to a drop in the pulmonary vascular resistance. The ligation of the umbilical cord at the time of birth also removes placenta from the newborn circulation and leading to increase in the SVR. The net result of the three physiologic changes in that there is reversal of the blood flow in the ductus arteriosus from the aorta to the pulmonary artery. A PVR decreases and the pulmonary artery pressure also declines significantly to approximately one half of the systemic levels. Approximately 1 to 2 months after the birth, the pulmonary artery pressures become close to the adult levels, and thus the size of the aortopulmonary window dictates a parallel clinical presentation. A small defect can be asymptomatic, while a large defect will lead to early congestive heart failure, pulmonary overcirculation, and if left untreated, can lead to irreversible pulmonary arterial hypertension. The extra flow is assessed as the ratio of the pulmonary blood flow to systemic blood flow, and the presence of the systolic and the diastolic flow through the shunt is similar to that seen in the PDA and leads to the earlier development of the pulmonary vascular disease. The lung development is often abnormal in neonates with the large left to right shunt and the increased body blood flow, and likely due to increased extravascular lung fluid. Cyanosis is rare, and if left untreated, a large aortopulmonary window invariably results in death in infancy. A smaller aortopulmonary window can be tolerated in childhood and even the adulthood, and if the diagnosis is missed, with the eventual development of the congestive heart failure, Eisenmenger syndrome, and potentially death. Unlike the arterial level shunts and the ventricular level shunts that occur during the either diastole or systole, the arterial level shunts such as aortopulmonary window occurs throughout the cardiac cycle. Patients typically present in the early infancy in the signs of the congestive heart failure, including tachypnea, poor weight gain, tachycardia, hepatomegaly. A murmur is not typically appreciated, and the peripheral pulses are bounding. And children may have increased vulnerability to viral infection, and chest X-ray will demonstrate cardiomegaly and increased pulmonary vascular marking. Echocardiography will confirm the diagnosis. It is important to identify seminal valves, as this will distinguish between the truncus arteriosus and aortopulmonary window, which will appear similar. In this case, the presentation of the cardiac catheterization is indicated to quantify PVR. The combination of tetralogy of the fellow and the aortopulmonary window presents a real diagnostic challenge, and left to right shunt through the aortopulmonary window may be palliative symptoms of tetralogy of fellow until the significant pulmonary vascular disease develops. Echocardiography will demonstrate the combination of defects, but the early detection is crucial. All the patients should undergo repair before the 6 months and the age, regardless of the symptoms. Contraindication to repair include PVR, 8 to 10 Woods. Repairs performed by medium sternotomy with the high aortic cannulation and bicaval venous cannulation. The anterior wall of the aortopulmonary window is open, taking care to avoid the coronary arteries. A patch is placed in the aortotomy, is closed while being incorporated into the anterior suture line atriopulmonary window patch. An alternative approach consists of a complete division of the atriopulmonary window with a patch closure of both great vessels. Occasionally, circulatory arrest is necessary for complete visualization and repair, and the transcatheter closure of the atriopulmonary window has been successfully attempted in isolated cases of the small defects and that was sufficiently distal to the semilunar valves, and in those patients with coronary anatomy was clearly identified with normal. Overall, the outcomes are excellent following the early repair. Operative mortality approaches zero for isolated lesions, and therefore the operative and post-operative outcomes are largely determined by associated defects with genetic syndromes. Risk of recurrent pleural fistula formation is low, and older patient outcomes are determined by preoperative pulmonary vascular resistance. Thank you.